Hi, we're going to talk about graded motor imagery and neurocentric approaches to treating pelvic pain patients, so patients with pelvic pain, and all the stuff that you can do and how you go about that. And basically, I'm going to pick the brains of the wonderful Sandy Hilton, who is a physical therapist from America. She graduated with a Master of Science in '88 and got her Doctor of Physical Therapy in 2013. She's contributed to multiple book chapters, papers, co-authored a book called Why Pelvic Pain Hurts. She's also an international instructor. She comes over to the UK quite a few times. She was over, I can't remember when last, but I was at her course, I think it was October last year, maybe earlier than that. It was warm in the summer. She speaks on lots of different stuff, lots of different platforms all over the world about how to treat pelvic pain, and does lots of public education as well. She's a regular contributor to health-related podcasts, and I'd really, really suggest you go and check out the Pain Science and Sensibility podcast that she does with her friend Corey, where they take papers and they take them apart and they look at the evidence, which is brilliant if you're a nerd or if you're into looking at the evidence and studying what is available. It really helps you to pull apart what's behind the suggestions and things that people are saying. She's worked with the section on women's health for APTA, which is the American version of the CSP, or TOGP would be our version of the women's health section. And she's now on the board of the Abdominal and Pelvic Pain Specialist Interest Group of IASP, the Association of International Association for the Study of Pain, which if you are listening to this and you're a professional, then hopefully you're interested in pelvic pain. These are your people. This is your tribe. And I absolutely loved going to their conference in Washington in 2017, which was absolutely game-changing for me from a point of view of learning, understanding, and kind of really set my career down the direction that it's going to continue to go. It was such a fantastic conference. So they're coming to London in May this year, 2019. So if you're interested, come and join us. It doesn't look too expensive either because it's in the centre of, well, for the centre of London, which is good. So without further ado, I will say hello to Dr. Sandy Hilton.
Hello, Sandy Hilton. Welcome to Talking with Me in Wales. It's nice to talk to you. I have no name for what we're doing. Today I thought we'd talk about graded motor imagery because we are both very interested in this. And I know we've had quite a few chats about different patients and things.
Yeah.
And I really want to pick your brains because I think there's quite a few of us trying to approach a brainy method to getting in with patients, and certainly having been on your courses, which were excellent, and everyone should go and go on Sandy's courses. They're brilliant.
Thank you.
It really brings the evidence to life of actually how you can apply the brainy approaches, which we're all kind of playing with. Mm-hmm. So I wanted to specifically hone in on GMI, but within that there's a massive amount of stuff. And start with the really massive concept of where do you start with GMI with your patients?
First, thank you to having me on. This is fun. I love the opportunity to talk, and then when I forget what we've said, I can go back and look at it.
It's an absolute pleasure to talk to you.
Brilliant. So where do you start? So the idea of, with pelvic pain in particular, that we're going to rehab it back to normal. So I think that's where I start, is the assumption that people can get back to normal. And that might sound like that's so easy, but really I think I can think of a lot of patients when they just started, they don't think they can get back to normal. There was a lady that I saw recently that when I asked, she carries her pillow around with her everywhere with the little cutout, and it's in a beautiful case that she takes.
She's only got one.
Whatever. She has one. She takes it.
Just one, not 3 or 4.
Wherever. Nope, just one. And then it might be one at a time because it's been some years. But when I asked her, what do you think about being able to sit without that? Just her body language was amazing, because she went from sitting comfortably on her cushion and pointing over to the chair, because I'm in my treatment room, like you can all see. She was sitting comfortably. I said that, and she shifted back and her arms crossed, and she went, and I was just sitting there going, wow, just so thinking about sitting without your cushion is enough to have a physical reaction of no thank you very much, that's gross. And And so that gives me an entryway of,
Yeah.
like,
Well,
noted.
it tells you so much, and on my course we talk about this a little bit, and I know you did as well on yours, that reading patients and reading their body language, and if you're an acupuncturist, then looking at their the chi signs, which are basically just autonomic tells that you really, if you're going to do anything with someone, you have to have the autonomic consent, and for most of the time that's normal. That's fine.
Right. And she was getting queasy with me sitting on my therapy ball, because I have a ball that I sit on, which is why I can go around, right? So I'm not sitting on a chair or a stool, I'm sitting on one of those therapy balls. Her watching me move on that was making her just get sweaty palms and full autonomic response.
Yeah.
And I didn't find that out till later, so bless her heart, she dealt with that for about 20 minutes before she said something. And then I tucked really close under the table and sat still, because that really wasn't the point of the moment, was to challenge that system. But those are the cues from when I first meet a person of, where are you now? What's normal for you? How are we going to get there? But then the kind of the testing the waters of how hard is changing where you are now going to be.
Yeah.
And if just thinking about doing a thing is enough to make your palms sweat and your stomach to tie itself in knots, figuratively speaking, then I'm probably not going to say, hey, jump right on that ball and you sit on it and let's prove that it's safe. Even though we know that it is, that's a lot. And there'll be all that autonomic top-down upregulation that I want to nudge, but not swamp.
And that's really key. I get a lot of questions.
I think that's the hardest part. And one of the...
Oh, sorry, go on. Hello? Oh, are we there? We've got a bit of a delay. Hello?
Yeah, nope, that was you.
Okay,
Rose.
sorry.
So
Hi.
you said that was key and you have questions.
Oh, yeah, no, I get quite a lot of questions from people that say things like, I've been referred this really hard patient from MSK, or she's had loads of treatment before, and you just can't touch her. And if you touch her, then it hurts. You know, anything you do, even thinking about it hurts. Where do I start? What things do I do to her to get her better?
Mm-hmm.
And I always think that that's also a really big, obvious tell that you don't start by touching them or going anywhere near them. Hello? Oh no, where's our internet? Oh, you back? No.
It is unstable.
Yeah. Oh well.
I'm here.
We'll manage it. Hello?
Hello again?
You back?
Hi.
Good. Okay, good. Did you get any of that question?
Sort of back.
Okay, I can't really see you moving, but I can hear you.
I did. I got you. Well, I did get parts of it. Okay. And we're going in and out. We'll work with it. See, it's just like therapy.
Yeah.
Just going to do it as we go. Yes, you were saying that you've had people that it just, like, talking about it hurts, so you weren't going to just go start touching it, was what I was up in, right?
Yeah. Why is this so
This
fast?
is perfect, actually. Oh, I don't know. Things have been kind of weird here. It could be on our side, but this is perfect because it's that check. Wait, what did you say? That really is very much like treatment, where you're having to stop and make sure and see if you're hearing it right. It's a great live demo of what it's like in the real world.
Yeah.
So yes, so we start with the assumption that people are going to get better. And I think that's key, because if I don't think you're going to get better, then where's my program going?
Yeah.
And them defining what better means. Not me defining what better means, but them defining that. And that can be tricky because sometimes people will have such, I'll say, low expectations of what they could possibly achieve that it's like, I just want to be able to sit through dinner without hurting. And that would be 35 minutes. And I might think, how about going back to work? But it's not my goal, it's their goal. So we can always readjust that as we get there. And I have a person right now that they're on medical disability because of pain and an inability to work, and quite capable brain and skill wise to go back to work, but concerned that they'd be able to do it. So the first goal they have is just to be able to be there for their kids, of, show up at games and go to their school events and drive them to something, and have put work pretty far away, as it might never happen, but if I can do this. And that's fun, because as this person's getting better, they're starting to talk about, so how would I put this in at work? And it's fun. I didn't bring it up, they did. And you can like, oh, look, your thoughts are starting to shift a little to where now what's possible is further ahead than it was before.
That's also key, isn't it? It's about getting the patient to lead you there, and having the patience to be able to know that you know the direction in which you're hoping that they will head, and you're going to kind of inch them and make little nudges, psychological nudges towards that direction. But actually, you can say to a patient as much as possible, well, you can physically work. Why can't you work? Of course you can.
Just go do it.
Yeah. So I always reflect on one of my patients who couldn't sit down at a desk, and she had a desk job for more than about 2 minutes without having extreme vulval pain and lots of other abdominal and pelvic pain. And she recently did a long distance sporting event. And so her emails went from being, I can't sit down, I'm never going to get to work, I can't do this, I can't do that, to then, I can't come back from a 40-kilometer cycle on my bike and it really hurts. I didn't prompt that. She prompted that. She went out and blew her limitations out of the water, and is now continuing to blow those limitations in such a superb way. So yeah, letting the patients lead you where they want to go. And at no point did I think that when I had this pelvic pain patient in front of me, that I would be saying, go and do some long distance sporting events.
Bike rides.
Yeah. Yeah.
We're going to get you to a 40K bike ride. Yeah. But if that's the thing that makes the person feel like themselves, I think physios and others are really good at helping you get there, to break that task down, whatever it is, into the components, start where you are, and then you have a plan to get to what that ultimate goal is, even if the goal keeps shifting. But it's kind of the heart of physical therapy, how I was trained.
Oh, absolutely. And I think that I would hope it's certainly the way I was trained, even if there was a lot of kind of snagging necks and lots of mobilizations.
Those two. But that
I remember knee extension.
You know what? So then with the given those things, the trick then, if there is one, is that you need to be able to be slow enough in the approach to this person to hear what their goals are, and to see what their fears are, really, if they don't just tell you. But like the body language of my lady I was talking about is pretty clear, and she's very smart, so I just pointed it out to her, and then she started picking it up, and we talked about something, and she's like, oh, it's doing it again. Like, yeah, that's a thing. So that's part of your homework, is to go imagine these things. And if just imagining someone else doing it is enough to get your palms sweaty and your stomach agitated and your symptoms to come on, then you know that that's tapping into that same process. And this is what I told her that they use for like Olympic athletes, of imagining yourself running the race and seeing yourself win, because we know that it activates a lot of the premotor cortex and all of that they can kind of run the idea through their head, literally. And putting that in a sports context tends to make it not feel like you're saying this is all in your head and you're just imagining it. It's like, look, here's what some really elite athletes do to get an advantage, because that's how humans work. So we're going to take some components of that and let you do that to rev things up and unhook this really protected response from thinking about someone else sitting.
And it's such a beautiful analogy, and I've probably stolen it from you. I am the product of every course that I've ever been on.
Oh, indeed, me too. So.
Yeah, and some of my favorite phrases come from all over the place. So I'm pretty sure I love that analogy of this is what we do with sports people, because it's really well known that if you imagine yourself winning, you're gonna perform better. If you wake up and think, oh, this is going to be a terrible day, oh, my pain, you're going to have more pain. If you wake up and go, okay, today I want to do these things, regardless of what's going on, then you're going to do those things.
Right?
So putting it in that kind of imagery perspective is definitely how I've sold more bizarre visualizations before. Imagine weeing without pain. Yeah, that kind of thing.
Right? In pelvic health, it gets really interesting because you're doing that. You're like, someone with testicular pain. So imagine sitting in a chair and the pressure on your testicles. Just thinking of that hurts. Well, imagine someone else sitting in a chair and the pressure on their testicles. Because that's the way it would go, is you'd watch other people sit and imagine how that would feel on you. And it's you end up thinking about it.
That pressure one I had today, I had a lady who has a lot of pain and pressure when she sits and is really concerned about damage to nerves, which damage is, I keep saying it's like a twisted ankle, your ankle gets better. It's exactly the same with nerves. But she was just really, really concerned about sitting on hard surfaces, which I really wanted her to start doing. And it's hard just to kind of say, just start sitting. But I know you want to. And so I ended up making her a cup of tea, because I have a clinic where I can make people cups of tea. And we had a cup of tea and a chat. And at one point I was walking around, I went, you know what, you've got nerves on the bottom of your feet that you've been stamping on for 40 years. And that blew her mind. And I went, they're exactly the same nerves. And actually they come from the same place.
And further away from the spine, so they've got a longer route for blood and stuff like that.
Exactly. And then she sat down for 5 minutes, which was
brilliant. Yay! Yeah. So it's the de-threatening it in a way that's true and provable and reproducible and dependable, and finding that someone can then, when they start to get flared up, put those things into process.
Yeah.
To calm them back down again. Because if we can turn it up, we can turn it down.
Yeah. Exactly.
You get top-down facilitation, fantastic. We can get top-down inhibition. And it all works. You just have to figure out how to make that dependable and reproducible for them in a way that makes sense to them, that's meaningful to them. So yeah, it's like, that's all you do. You just do that.
Which takes
so easy.
Which I think the skill in this is what we're so called the soft skills, but it's actually a greater degree of understanding of pain science and understanding of humans and
physiology. You got to know, you have to understand the physiology and what's possible and probably not possible.
Yeah.
So that you can aim your time in the right place, or a helpful place. You really need to believe that people can get better, and that sitting isn't dangerous, that you're not going to undo anything if you sit on a part. Because I love you about, we'll borrow that from you, about you've been walking on your feet this whole time. It's fine. And those are okay. And when your feet get tired, you sit down and you get off them, and then they're fine again. And you can go do it again.
The one I use when I'm exasperated. So I'm sorry to anybody that might be reading.
That hears this, they're going to go,
oh, yeah. When I really need to get through to someone, is I use the, when they really don't believe that they can change. And so I know that I'm not going to get anywhere unless I can either send them to psychiatry or psychology or counselling, or I can just have one more putt at trying to inspire that they can change their own bodies and believe that. There's a really famous thing on YouTube, the army veteran who he did yoga. He couldn't walk.
Yes.
Matches, and at the end, he's standing on his head and running loads. And he was he was addicted to painkillers and all this kind of stuff. And all he's done is rehabilitate really well. Exactly using these processes and thinking himself there, and lots of practice and a graded approach to it.
Right.
So I send them that. Watch this. Then
watch
think
this
about
person.
how it applies to your life.
Yeah, and it's.
I wanted to ask you about FODA, because I was very, very happy to receive these. I bought them from you earlier from the Entropy website shop, which is very useful as physio tools. These are FODA cards.
See, I have mine.
Of things like these, but also.
I feel like, look, that was the one on the top of my pile. It's like Jilly and I are playing cards.
Yeah. Very good. But like nice pictures of people cycling and doing everything in the world. So talk to me about how you approach using FODA.
Well, I don't use it with every single person. And I probably could start. There was one lady that I just saw today that I in retrospect, that would have been a great thing to do, but I didn't. I will get them out next time, but she was a little overwhelmed. But because there are pictures, there's no words on them. What I will use when someone, like if I asked you, what do you know, what's going on? What do you want to do? What would better mean to you? And you have answers, I'm unlikely to get the cards out. But if someone's like, well, I don't know. And so, well, what would you like to get back to if this was gone? You know, there's a phrase people will use, if I could wave a magic wand and make your pain or your discomfort or whatever's going on go away, what would you do? And they're like,
clean the house.
You know, what do you do for fun? Then it's been going on so long that those things have gotten lost a little. So I like getting the cards out, and the instructions based on the standardization that was done for spinal pain, back pain, is where the original photo cards came from. And then there's a set for pediatrics. And you ask them to rank the cards in order of easiest to hardest. What we're doing is take the cards out that are meaningful to you, because not everyone's going to want to go rock climbing or anything, and take pick the pictures that are meaningful to you in your life, and I want you to rank them in easiest to hardest. And then they tell me about them. And if you've ever had children draw you art projects, you just say, tell me about that. And then you stop talking and let them say it, because it's like one that I had pulled up to show that's a pair of jeans or pants. Mm-hmm. And some people would look at that and say, I can't wear jeans, the seam bothers me. And other people would say, you know, those are the clothes I'd go out dancing in, and I can't go out dancing. And or I can't go shopping. Or so it's not something that I try and interpret. I wait for them to tell me what it is.
Yeah.
And then I take notes, but then I also take a picture of it and put that picture in their chart. And then sometime later, because now I have the cards that they were meaningful to them, and I pull them back out and say, this is what you did last time. Is this, you know, do you want to change that? Does this still fit? What do you think about this now? And that's always an interesting conversation, but really it's a way to get the conversation started of how comfortable do you feel in your body doing things, and where are you right now, and where would you like to be?
I really, really appreciate the photo cards, because I think that it does exactly that. And especially if, certainly in my practice and how it's developed over the years, that I'm very much more comfortable being in a vulnerable space and sitting and not doing physio, mobilizing, pulling things, stretching things. I'm quite happy just to spend an hour talking to someone. But when you're not, and you may be, certainly, I know in the NHS aspect, where there is an expectation that you do something every time that you see a patient, knowing how to even begin to approach someone who has been to pain clinic and come to see you, they're the most chronic of chronic patients. These can be really useful. So that there was a patient the other day that I put it on Twitter. There was a really funny book by a junior doctor with a little excerpt about, and I loved all of it. He's junior, he's up to a registrar. He was an obs and gynae consultant nearly. And there's one thing where he has a run-in with a pelvic pain patient where he has no idea what to do. And he just says, well, there's nothing wrong with you. And she ends up throwing a box of needles at his head. I know. And he envisages how many forms of HIV he can get. And it's all very funny for his anecdote. But it broke my heart, because it's the wrong conversation. And it's that I really hope that patient made her way to somewhere useful at some point.
Because the words, there's nothing I can do for you, really should be emphasized on the I, and quickly followed by, here's a referral to some people who can help you, that have skills that, because I think what people hear is there's nothing that can be done.
Yeah.
And what's probably meant is, this isn't something I can help you with, and it can be helped. It's just not me that's going to do it.
And to be honest, I think a lot of them don't know that it can be helped. And we can have that chat another time.
That's why I said, how does this start? Graded imagery and graded exposure to treating pain and the sensory integration techniques need to start with the understanding it changes.
Yeah.
Because if you don't think it changes, how are you going to design a program to create change and monitor the change and progress the change to keep the load enough to make a difference?
Yeah.
Because if you underload it, it's not going to change.
And
So
we endlessly underload in pelvic health.
Totally, those
We load with
ridiculous
one finger.
pillows.
Yeah.
And those pillows of here, sit on something that takes it out. And I'll tell my patients a lot, sorry for anyone who's ever heard this before, that if you get a cramp in your foot, what you do is stand on it.
Yeah.
You don't lay down and put it on the back of the sofa and wait and use crutches and wait. But people have a cramp in their bum, and we give them this pillow to sit on to offload it and tell them not to sit on it and not to squat and not to do all these things that actually put the right pressure and movement through there to uncramp it.
I'm going to steal that one. That's very good. I like the cramp analogy.
I think that's, but what we don't do, and where it works with my patients, because they're like, and I'm like, well, what you also don't do is you don't stand up and start running. You put weight on it. You don't start hopping on it. There's a middle ground there that you load it enough to make the cramp go away. But
it needs more knowledge and more awareness for people to be able to say this with conviction that they know.
Right. And they have to know that things change. And that sitting isn't dangerous. And you're not going to damage anything by putting pressure on it. You're made for that. It's like your feet. That's perfect. So I'm not scared of them doing it, and that comes across in how I talk. I know it's okay. We do crazy things with sitting, like your lady that doesn't like to sit. We'll do perching on the windowsill of our clinic, where it's just your ischial tuberosities there, and it's part of your body weight, and it's just that, or sitting on the corner of a yoga block on a regular chair, because you have different kind of pressures, and then like doing this kneeling, but kneeling onto a yoga block so that you have a little pressure in the perineum and you can grade it. So there's nice. all sorts of different ways to start introducing pressure of your body weight onto a surface.
And Shelley Prosco's got quite a nice yoga sequence about that, with kind of kneeling over a yoga block and movements that you can do, and rocking and rolling in different yoga poses. Nice.
Yeah, and different. So you'd grade that exposure too, from softer to harder. So you can start with something squishy and move to doing it on a foam roller, of sitting on that. Or we have plyo boxes for plyometrics. Sitting on a corner of one of those is like sitting on a rock. So we go from softer to harder and just keep varying heights and things. And then pretty soon they're like, all right, I can sit on anything. This is boring, which is exactly what I want.
Yeah.
Because sitting down, unless you're exhausted, really shouldn't be terribly exciting.
Which is a great way of putting it. I've definitely started using your good, bad, and boring, and having to tell every patient, when I say good, I mean it makes you feel nice in some way, not like nice, but
well, sometimes we want them to go for the nice.
Yeah, but not generally during therapy. But like, it makes me feel better, or it makes me feel worse, or actually it just feels. Okay, so when we've done the kind of photo stuff, do you do any laterality testing? And how do you do that?
I used to. Some years ago, I would run through the recognized program with the feet and the back. The hands didn't seem to do much. Honestly, it didn't really seem to do as much as just getting people to be aware of the area.
Okay.
So if they really, so I would pull that out for someone that if I can't get them to be okay and know where their body is. Their proprioceptive awareness was not there. You're doing a sensory test vaginally or rectally or externally, and it's like, can you feel me? And they're like, no. Can you tell the right from the left? No. Then I might back up a little and say, well, is this a sensory thing, or are you just not paying attention to that area?
So I think it's two patients at the moment that I'm playing with that. That I talked to Katie Kelly about this because there was one patient a while ago who I couldn't even show her the model of a pelvis or begin to explain any anatomy, because she just balked at the idea, and she couldn't look at her granddaughter happy. And so actually I did some laterality as a way, as almost graded exposure to pelvises. Pelvi. Yeah,
that would be a perfect example of when it's like, okay, how do I back this up?
Yeah. What the hell do I do now?
Program that isn't pelvic, but it makes we know from the studies that have been done that it really runs activity in the premotor cortex and the motor cortex and the sensory cortex. So we're getting activation of all that area of a place that's less threatening, and then you can move to it. But we always need that. How do I back this up?
Yeah.
That would be perfect.
And certainly, I think I used to be playing with this kind of stuff, but having done the research, and you've got to know it to be able to say it to a patient and that this works, and be able to say it easily. You should be able to explain anything easily, but not being patronizingly, because patients can understand. So with her, that I did some, and there's another patient that again has just been touched by lots of people, and in what they think is the one useful way.
The way to do it, yeah.
Yeah, which in many patients helps, but it just didn't. It's just riled up her chronic pain. So I've been trying to go through a kind of desensitization process, but and her laterality is improving, but we're not getting any carryover. And so that's why I clinically reasoned with Katie and said, look, how do I jump to implicit or explicit imagery? And how do we grade it? Now, the caveat being that I'm using acupuncture, which I rationalize as a way in, a buy-in, and some serotonin. And she's had the best pain relief ever because she trusts me. And it's the only time she's ever had any relief from this pain in 20 years. So
very nice.
Yeah, don't really want to be doing it endlessly, but it's certainly a way of getting buy-in and getting the beginning of moving forward. So where, I know that you just talked about a little bit about getting patients to think about doing stuff. How would you then approach kind of jumping in on that?
There's so many, this is where it's like, there's a doc here that wants a protocol, and I'm like, there's
no, I know.
It's principles. So
say that you balked at the idea of sitting or doing anything.
I did an absolutely zero physical assessment on her, which was funny when you were saying I'm comfortable sitting. That even a year ago would have driven me crazy. It's like, I don't have any objective data, and it's like, that's not really objective anyway. I have different data to start with, and so we have a plan. I pushed her as far as I could without the sweaty palms and crossed arm pulling back away from me. So okay. It's like and I know from having messed up that, like, I was writing down things that were a problem for her sitting, wearing clothes that are close up to the perineum, and some other things were fine. Those things are hard. Exercise flares are up. So we were talking about things, and it was like, well, of those three, so let's say it's exercise, sitting, and so getting back to regular exercise, sitting without your cushion, and wearing whatever clothes you want to comfortably, which of those would you like to start with? So I kind of,
again, give it
after the discussion, I kind of narrowed it down to, of these three that you've identified, and she identified, which one do you want to start with? So she picked. And nice. And that's good, because she then has the self-efficacy, and it was her idea, and I had her help me design the program of wearing either tights or nylons. Ultimately, nylons bother her right now. She can kind of wear tights, and there's a reason that she has to wear them for a certain amount of time. So it's like classic graded exposure. Can you imagine yourself sitting or standing in nylons, and how does that make you feel? And she goes, yeah, I can imagine it. And I was like, if you put them on, think about actually putting them on. How does that make you feel? So we were running the imagery, and then I was like, how long do you think you could wear them? Mm-hmm. So if you think of this like a little virtual reality game, so here's her little icon of herself that thought about nylons and then put the nylons on, and then is standing there in nylons. How long do you think you can have those on comfortably? Could you do an hour? And she said, like an hour. And I said, would you be comfortable? And she kind of made that face. And I said, how about half an hour? And she went, oh yeah. And I really looked for that solid yes. And I said, great. So that's where I want you to start today, is go home, do this, set a timer. You can't do it longer, even if you feel fantastic. Take them off. I said, and then the other question is, tomorrow, how big of a chunk are we going to increase this by to get to your 4 hours? And she picked 10 minutes just right off. And so to be 30 minutes today, 40 minutes tomorrow, 50 minutes, and then it's just every day. And if it flares a lot, then you drop back a couple times and start from there. You don't start over and you don't stop. You just say, I've achieved this and I've achieved this. That's really hard. And it flared everything up. I'm not going to go 10 more. I'm going to go back to that one and do that again, and then keep progressing. So you kind of got this little safety net in your head that doesn't say, if it flares up, you're done. You have to start all over. It says, well, that was a little much. So let's go back to where it was okay. And
that's
going.
the key. I think that can take a lot of time. And B, certainly within physio, that can feel like you need to progress. But actually a patient may need to spend 3 weeks at 10 minutes. I can think of a lady that
I try and make it like I would do it then if like if you could do 30 and at 10 minutes was too much, it's like, let's try 5. And okay, 5 is okay, but even if it's just 1 minute, I want that consistent amount, because what you're doing is saying, I did 30 minutes yesterday. I'm going to do 40 minutes today. I know I can do, it's just 10 more minutes than what I did fine yesterday. I survived. And then now you own that. And now that's your baseline. So then it's 10 more minutes. Now you own that, and that's your baseline. So you don't get to stay. You have to keep progressing, even if it's just a little tiny bit.
But there's power in the ownership of it, and the fact that they can stay. If they're only doing 30, they
can or you can drop down a couple and then keep going. Or we can say that's too big of a bite for right now, and we're going to do it for 1 minute in between. Because I'm looking for them to go like, this is so easy. And so boring. And so they're ridiculous. I could just do this. That's what you're looking for, because the tissues themselves, that's not going to damage anything in the perineum. That's a sensory tolerance. You could wear jeans, the worst made pair of jeans with the seam right there. It's still not going to damage anything. It's covered by the labia. It's protected by fat. It's you're safe. It's a sensory discomfort, which is excruciating. And I don't mean that to be minimizing at all, but it's physiologically safe.
Your head is not harming you.
Yeah, not at all. And so then to prove that, you have to start with what you can do, gradually continue, and then not give that ground back, because you own that. And then we'll go back to sports. It's like a running program. You can do 10 miles, an 8-mile run's okay. You might have the flu and only not even want to run. That's all right. But if you're off for a couple of weeks and you go run again, that 8 miles might hurt, but it's safe. And that's normal and expected. So I just keep pulling it back to that, and I keep thinking of what I'm really doing is strength and conditioning for the pelvis, the inside of it. It's like, we're going to load this enough. We're going to calm it down. We're going to load it, and then
it's a really good analogy. I'm just going to stop my thingy from screaming. It's very cold here, so the radiators are on loud. It's the same analogy. I've got a lovely girl at the moment, one of many actually, that are doing the same strength and conditioning with sex. And that's the way that she certainly understands it. I mean, she's got a few other comorbidities, but sex is something that her and her other half have not been able to do for a long time, and they really want to have babies. And to have babies, you have to be able to have sex or implant. And when we talked about kind of, weight training for the pelvis, she was like, oh, okay, I get it now.
I get it. Reps. You want me to do reps?
I want you to use your dilator or your wand or your thumb, or we've tried lots of different things until actually she's really okay with dilators. I tend to be massively feminist about dilators. I'm not a big fan of them, but she really gets on well with them. She likes lying back and thinking of England, and tolerating them.
It has to be what they like.
Exactly. So, which is fine with me. So she's doing that, and actually that's and she gets it that's like it's a tolerance thing. It's weightlifting, it's training, it's getting used to doing these things, because in the back of your mind that they just need to have. Well, they don't just. When they start having regular sex and they keep having regular sex, it will all all of this will go away.
keeps it normal.
Yeah.
Yeah. And in a way that doesn't trigger this top-down protective response. We want it to actually be enjoyable and fun so that you get all the right reward. But yeah, so that's exactly, it's that trying to find the words that are going to make sense to that person, and we can know the scaffold of the rationale behind imagery, laterality, and can do a body awareness and the ability to think of the part without triggering symptoms. And then using it where you can, and progressively making that harder to normal physiology for whatever you want to use it for. But that looks so different for every person.
And often I find it's only one thing. So if someone's fixated on the fact that they can't sit, that'll translate into them then being able to have sex, or as well when we get them sitting. Or if they can't have sex, that actually that'll translate them into them being able to do long distance sitting, or riding a bicycle, or, you know, being able to insert a tampon.
Yeah.
Which can be so separate, but it can be
so literally it's whatever way do you get into that system, and then things just start going back.
But I think it's key what you said there, that you need to be able to have the good physiology understanding of how the brain works, in knowing, in projecting an understanding of what it thinks is going on. So first is that kind of, and I'm not going to explain it. It takes too long.
You're doing great.
And you should be able to explain everything easily, she says. But it's so I can't explain it as beautifully as Laura Moore and the rest of them that have in the Graded Motor Imagery book, which is a good textbook.
Beautiful book, yes.
Really good, really easy to read, puts everything into context. But then when you've got that, then also understanding threat and pain, and keeping everything that you do sub-threat, so that you're not scaring the patient, that they're not going home having to kind of dig in and relax around something, or manually do something, or look at themselves if they're not ready for it. You need to get their consent and their autonomic consent, and they need to be leading it.
Mm-hmm.
And I think that's often where people fall down, is that those skill sets aren't necessarily something that is expected of a lot of people in our profession straight away.
And I think it's critical for this, because you're also, as part of what you're saying, you're also changing that person's expectation. So like you said earlier, if you wake up in the morning and you're thinking this is going to be a really hard day, we know that physiologically there are different systems running than if you wake up and think this is going to be the best day of my life. You have a whole different chemical base. And that makes a difference, especially in a sensitized system. So I want to use all of those possibilities. And if they start thinking, not only is this a patient that I had a while ago that had to take an anti-anxiety medicine to come to therapy, because therapy had been so horrible historically that she had to drug herself to be able to be calm enough to come. Very happy that that's not true anymore.
That's terrible. It just makes
right. So if just thinking about going to do the thing is enough for you to get so anxious, you need
drugs
to take something to calm it down so that you can go endure the thing. That's not working the systems that I want to work.
No. And that's another, is again about I talk at length to my bladder heroes that we talk about body language. We talk about when you make your initial approach, about making that first impression on your patients as absolutely key. If you go in delighted to see them, even if it is 7 o'clock, but you've still got the I'm happy to see you, I'm showing you I have no weapons, and you do all the kind of the subtle physiological cues to make them at ease, and then you say the right things and you listen to them actively, you can automatically bring that threat level down in their system. And
you can watch it. You can watch the body language change. You watch the breathing change, and the breathing pattern changes from guarded to not as guarded, and people just sort of settle into themselves.
And the using that active, completely leading language. I am, unless I'm very, very tired, I'm very rarely not in control of what I'm saying actively in a session. So the way that I say things will absolutely be leading people in one way or the other way. I'm sorry, patients, if you're listening to this, but I know this is difficult when you try and do really cool, fun, informational chats. with people that you think are incredible and have got loads of knowledge, because you give all your secrets away. But
well, and also we anonymize our people so that like I can think of like 40 different patients that would think I just talked about them because you smush things together in a way that it doesn't
everyone's a different gender, different age group,
different gender, different
patients aren't patients. But we both done enough teaching that these are all patients that we're digging out of our mind from a long time ago. But it's one of those things. If you say to someone, if you're about to assess them, I always say to every patient, physio shouldn't hurt and it won't hurt. Every single session to patients, if they're fearful, physio won't hurt and it shouldn't hurt. If it hurts, we stop, we adjust, we think about what's happened, and then we'll go again. And if you say to someone, like the first time I assess them cold, so I won't do anything to make them particularly pain-free, apart from all the usual things that you do to put them in a nice position and deflect and all the rest of it, just to see what their system is actually trying to say. I'm actually assessing them if I think it's a suitable thing to do. But then I'll back out and be the next time I go and I'll go, so having done all this work, this should feel a bit better. So they're already cued into the, oh, this is going to feel good. Do you do anything like that?
I do something like that, of the definitely, I don't need to make you hurt and this shouldn't hurt. It can be challenging and it can be hard, but that's different than that you need to stop. And, because sometimes what we ask them to do is hard, but then we go back to sports, like, that third set of weightlifting is hard and it might hurt, but it's done as soon as you're done, and it's not. It's like, that's okay. A hard, that feels good is different than I'm dying and I'm going to lie here and endure it.
And you've got through it, and you've known that you've achieved it. So
those are all individual. But then yes, it's like, okay, so how much? Well, sometimes I'll say stuff like, so how much better is this than last time? Just totally leading, and then what would it be in a court of law? That'd be like leading the witness.
But exactly. If you're trying to get objective data, you need to say, I always say something like, I don't mind if it's worse, or,
or better, worse, or no different. Let me know. And constantly it's, I can't feel what you feel, so I need you to tell me. I'm not going to make an assumption of how this feels to you. Even by facial expressions, I need you to tell me. But I will, and I always tell them, I'm always watching your breathing, because if I'm doing something and you stop breathing and your face does this, I'm going to assume that that's a little overwhelming.
And
or you need to sneeze or something. But so you pay attention, because you're working on someone and we can't feel what they feel.
But
it's hard, but it's fun. Does that seem weird? It's not that I like people hurting, it's that I like helping them not. And
I think the beauty is in the complexity of it, and the way that you've just described how you work is really beautiful and very kind of holistic in the truest sense of the word, that it encompasses their true thoughts, beliefs, desires, and
really, I think that's the way that it is most helpful and most sticky for them, so that when they leave, they know that it's a program that's meaningful to them, that they helped design, and they know they can change it. I talk about like having your own little words are missing at the moment. So like guiding you towards what's better. And it's just better, and just keep going that way. You don't have to go into what's the hardest thing to do. You can keep choosing what feels good. That still puts load on the tissue and gets people going. Is your cat woken up?
He's sneezing. It's very cute, but I'm a bit worried he might then vomit.
Cat puke.
That's fine. No. We're just sneezing. We're going to leave it at the sneeze. But
so before we started, I was telling Julie that my last student made, this is no longer a PG rated video. Do we have to put a disclaimer?
Fine.
Or I just hold them really far back?
Quickly.
Right. So we have 3 different sets of like these little additional cards that I had my last student make, of a boy and a girl theoretically having sex or doing really hard Pilates, but also boys and boys and girls, so that when we get into specifics of, okay, it hurts when I have sex, but exactly when and what is where and how does that work, we can do kind of that same thing of saying, Okay, so now we're going to get into when you're being intimate with your partner, what's easier or harder out of these? And they're just randomly selected, but again, it's a conversation starter. Interesting. So they're kind of in beta right now, where it's like, if it's a guy, I know I'm not going to put the two girls out, and if it's a girl, but I just put the piles in front and say, pick whichever one works for you and go, because not often do people come and tell me exactly who their partners are for intimacy, and it is, I think, important to not make people think that they can't talk to you about what they need to talk to you about. So I mostly just try and ask very open questions that could be whatever, but still get the information I need, and then try and lead into so when you're being intimate, and find out the detail that we need to be able to problem solve physics and pressures and things like that.
That I can't wait. I really, really, really want you to produce those as another pack of these, which have been absolutely invaluable to my practice, just as starting conversations, because there are only a few patients that are able to really talk in depth comfortably, and actually maybe having another way of inviting them to say all of these things are normal. When I've had only a few in-depth conversations, one being about someone having sex in a doorway, which actually a lot of people do, and it took a long time to work out that it wasn't the position, it was the voyeuristic angle of having sex in front of somebody else, that actually was making it not hurt, versus other methods of sex, because and it's all sex is normal as long as it's consensual, and we're not here to judge, we're here to get people better. So that may not be within my personal vocabulary, but it's something that I have to be open to discussing, and the only way that I can be open to discussing ways that I'm not familiar with is by having cards to say, someone can say, it's kind of like that but upside down.
But yeah, if you take that one and this one and you put them together like this, then it's kind of, get a whiteboard and some pens, draw me your own. But because again, we can't feel what someone else feels. We're not there, and please don't bring it in. That's not in my comfort or therapeutic realm. There are counselors, there are sexual counselors here in Chicago. There are some fantastic counselors that can really get into couples therapy of, okay, I want you both to come in and let's have a talk, and can help them in things that are outside of my realm. And I love having their names because I will refer.
In the UK, we've got really good access. Well, I've got really good access at the moment.
It's not everywhere here in the States. I'm lucky in Chicago. I've worked places in other states where there weren't any, but a lot of those people are also now doing telehealth. So even if you're in a remote area and there isn't someone local, there are people who can now help you anyway.
That's so useful.
Which is really nice.
But when it comes down to just the actual biomechanics or sensory or logistics,
I can break it down into the physics, and I can make sex really not sexy for that kind of stuff. But then when you want to work on intimacy with your partner, you might want to go to someone who will help you with that. But
then the photo cards are going to be useful. Well, Sandy, I've kept you for nearly an hour, so thank you so much for
it's so much fun. We need to talk a lot more about this, because the research just hasn't been done yet, although I understand there's a couple of people doing some.
Yes, I'm hoping that we are publishing sometime soon. You're doing something as well.
I'm doing a clinical practice guideline for treating pain, but because Katie's stuff isn't published yet, it won't be included in it. And I just steal heavily off of the CRPS data and studies, and assume that it's reasonable to think that humans work similarly, regardless of body part, and that the pelvic structures are more sensitive than the hand even. So we can use that, but don't really have evidence yet. So I'm excited that these conversations are happening.
Yeah, there's really good crossover as well between the back and the foot and things like that as well. So there's all the evidence that, there isn't all the evidence. There is some suggestion.
There's some suggestion and some suggestion that it might even be more segmental levels in the spine, which can give us even that makes some more of the yoga makes even more sense. And and other things that we find helping people be like, oh, well, it's probably because of that. And then we can use that and build it into our programs. So it's an exciting time in pelvic health.
It is. If you're super geeky like we are about
Yes.
people and getting their brains to help them get better and getting them moving and physically doing stuff, as opposed to, and don't get me wrong, I use my manual skills all the time, but
me too. And sometimes while I'm talking to them about all this stuff, I'll do my manual therapy that makes them feel absolutely lovely, and talk to them about things while I do it.
Get into their brains.
Right? That's what, like, I'm just going to put this little thought in there and let it percolate for a while. I want to do a commercial before we get off. The 4th Abdominal Pelvic Pain Conference, I've been told that the registration is up momentarily. About 2 hours ago, they said it was up.
Amazing, because I was actually going to ask you on behalf of Hannah DeBoer and I, who keeps tweeting you.
I am so glad, because every time something comes on Twitter with that, I can screenshot it and then send it, because it's one of the challenges of working with a really large organization, as you know, in NHS, is you are one of many voices asking for attention and assistance. So every time someone is asked, I have pass that along as a voice asking for attention and assistance in getting the back end of this all working well, because we want the registration process to actually work when it goes live. So that it's
in May in London, isn't it?
May 11th and 12th in London. And it will be a conference-based, it's a little different than the other ones have been. Katie Vincent from Oxford has really had a large hand in putting this together to span challenges in the abdominal and pelvic health world, but also across the lifespan. So we'll be talking about some pediatric things and some midlife things and some older life things in all genders and ages. And it's built around that.
Brilliant.
And pretty heavy on the evidence side. So it'll be fun.
Is there a pre-conference or a post-conference that you're aware of?
At the moment, we do not have a pre-conference, but there might be. So hang on for that. We had to get the whole thing up first.
But we will definitely be there drinking cocktails.
We are going to have an amazing night of we're going to put the posters and the platforms woven through everything. And the poster presentation, that's going to be open now too. So you know how sometimes at conferences the posters, which are lovely, are smushed off somewhere and you sort of get time to see them? This is going to be woven through everything to try and get as much exposure to the young researchers and the new evidence that's coming out as possible. And a really fun cocktail evening, and local talent musicians that are going to be also highlighting the research. So it's going to be fun. We're gonna geek out and play at the same time.
Can I add my voice as well? Oh, go on.
And you know how in some conferences, like, yoga is really good and helpful, and sometimes they'll have like the 6 o'clock in AM thing.
Yeah.
Sarah has been voluntold that she's going to weave that throughout the 2 days. So regular human clothes on movement throughout the whole conference.
Sounds perfect. So we're going to be up and moving. I will. I'll add my voice to that. Coming to the last World Congress in Washington was an absolute game changer for me. I met all of these people that I've been reading for years. It filled my brain with so much research that was just so exciting. And the bit about the conference which I loved the most was speaking and meeting everyone and having continual dialogue, which is, as we can see right here, we are talking, is continuing 2 years later, well, a year and a half later. And it's just one of the most exciting conferences I've been to. So if you're into treating pelvic pain or understanding it, then this is definitely the place for you to be. And it's in London. So come on, UK folk and POGP folk, come on down to London and have some cocktails with us and do some yoga.
Yeah.
We'd learn lots of things.
We'd learn lots of things.
Marvellous. Well, I'm going to say thank you very much. And it is a delight to hear from you. And thank you for talking to us about your approach to kind of the mind and pain and how you guide patients in the right direction. And I look forward to further conversations. And
yeah, me too.
Alcohol in.
We'll have some gin. We'll find some gin. Yeah, no, I love reading what you're doing, Julie, because it gives me a lot of really good ideas. We are all learning as we go, and right? Reasoning, but yeah, sometimes enthusiastically, but sharing it with each other really just shortens the time, and we all get better. So yay.
It's one of the, I read just to finish off with, we should all be not afraid to do this. And one of the things I've learned from certainly being out on my own a little bit more in practice and having to reach out internationally for clinical reasoning and thought processes is that the value in actually saying to someone, I'm doing this, I don't think it's very good, what am I doing wrong? And being brave and vulnerable about it. There was a paper I read, one of Dr. Peters, Mr. Peters' groups, the Gupta paper 2015, which outlines their ideal MDT. And I didn't agree with all of it, but it was beautiful because it actually showed step by step their ideas and their processes and how they approach patients and what kind of pathways they've got. And finding that level of detail it's unknown, really.
Yeah, we don't have it, and we're gonna have to do a lot of trial and error to narrow that down a little bit, to get more, I guess, to ask better questions of our patients and to know what to highlight, because it's been shown to be more helpful. Should help move things along even faster.
Yeah. So let's keep talking. And thank you very much. I'm going to stop the recording now. And I'm sure I'll talk to you very soon.